I'm going to record the meeting. Our presenters today are Alison Blum and Alex Pattison. They're both outpatient therapists here at Lenape Valley Foundation, and they are wonderful. If you have any questions that come up during the presentation, please type them in the chat and we can answer them at the end of the presentation. And I hope you enjoy their content, and I will let them take it away.
Thank you.
Thanks. Hi, thank you so much for attending our workshop this evening. My name is Alison Blum. I'm a licensed marriage and family therapist at Lenape Valley. With me today is Alex Pattison. She's also a licensed marriage and family therapist, and she is actually in training to become a certified eating disorder specialist. So this is totally her area. So please take advantage while she's here and ask all the questions you want. Since it's such a low attendance, also it's totally fine if you want to unmute yourself during the presentation and ask a question. That should be totally fine. It probably won't interrupt us too much. Later on in the presentation, we'll be joined by Dr. Nuthi. She's our child and adolescent psychiatrist on staff at Lenape. So she will give some information on the neurobiology piece as well as medications for treatment. So I like to start these workshops just to give like a kind of like a general idea for people who are like seeking treatment for their child or teen, or maybe you're in treatment with your child or teen, just to give you like an idea when you're coming into treatment. This is some of the stuff that maybe would be helpful to know. First of all, that there is an age of consent in Pennsylvania, which is 14. So what that means is that if you have a child that is 13 years old, you can sign that child up for therapy, you can consent to their treatment, you can be involved in their treatment planning process, you have say in who they do and do not share information with. But if they are 14 and have reached the age of consent, they actually have the say in doing all of those things. That being said, of course, it's very much encouraged that parents are involved in treatment or caregivers. You know, I usually am very upfront with my teens and saying like, you know, these are the things I would be sharing with your family if need be. And if I think that something needs to be shared with your parent, I'm going to let you know about it, but I'm going to share it because I just do think it is very important for that to be a part of treatment. But basically, like if they want to be in treatment at the age of 14, they would be the ones having to consent to everything and sign for everything. And if they don't want to be in treatment at 14, then we actually cannot force them to do so. So we're talking about eating disorders today, and there's so many different ones. There are a couple that are, of course, are a little bit more well-known than others. So I am going to talk about the ones that are a little bit more well-known. So first of all, being anorexia nervosa. So it's more commonly just addressed as anorexia. And that's when basically the person is restricting. They're not eating enough, they're not taking in enough energy, leading to significantly low body weight for their age, their gender, sex, their developmental state, and their physical health. There is also an intense fear of gaining weight, becoming fat. There's persistent behavior that interferes with the weight gain, even through, though at a significantly low weight. And there's disturbance in the way in which the body weight or shape is experienced. There's undue influence of body weight or shape on self-evaluation, and persistent lack of recognition of the seriousness of the current low body weight. Bulimia nervosa is another one that's common. So again, more commonly probably addressed as bulimia. This one is where there are recurrent episodes of binge eating, inappropriate compensatory behaviors that then follow the binge eating. So the binge eating is when there's a lot of food, more than what most individuals would eat in a certain period of time, is consumed in a certain period of time. And there's a sense of lack of control over the eating during the episode. So the compensatory behaviors that follow that are often self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, excessive exercise. All of these things can be what people do to then compensate for the fact that they just ate a lot of food. The binge eating and inappropriate behaviors occur at least once a week for 3 months, and self-evaluation is unduly influenced by body shape and weight. This is the last one that I'm going to talk about. Again, this one's a little bit more popular. I don't know about that word, but well known, I guess I should say. And this one is categorized by recurrent episodes of binge eating, which again, kind of like what we said on the last slide, is when you eat a large amount of food in a certain period of time, which is more food than one should consume in that period of time. There's a sense of lack of control over eating during that episode. The person eats more rapidly than normal. They eat until they are uncomfortably full. They'll eat large amounts of food when they're not feeling hungry. And they may eat alone because they feel embarrassed about how much they're eating. They also might feel disgusted with themselves, depressed, or guilty. And there is distress regarding the binge eating.
So I'm going to talk about some of the other eating disorder diagnoses. So a lot of these are not as commonly treated, but does not mean they're not as serious. So all the eating disorders I'm going to talk about all should be taken seriously, and all can be quite dangerous. So first, I'm going to talk about atypical anorexia. So atypical anorexia is essentially the same thing as anorexia, all the same symptoms Alison discussed. The only difference is that someone with atypical anorexia is technically not considered underweight. Unfortunately, because of this, a lot of people are not treated properly because of that. So just because someone is not underweight does not mean it should not be taken seriously. So again, atypical anorexia and anorexia are essentially the same thing. So anorexia is anorexia, and despite someone's weight, they should be taken seriously. Unspecified feeding eating disorder and other specified feeding or eating disorder. So what this is you meet some of the criteria for an eating disorder, but not all of them, or you meet some symptoms of different eating disorders, but not all of them. Avoidant restrictive food intake disorder involves decrease in appetite or food avoidance, fear of vomiting, and this is essentially a sensory eating disorder. So because of the avoidance of food, this is not the same as anorexia where you're purposely restricting, is there's a little bit of a sensory issue involved with it, or a fear of getting sick because of a certain food. PICA, so this is the eating of non-nutritious foods or items. So this is when an individual compulsively eats things that are not necessarily food. So an example of this could be like something like chalk or fabric or metals. Obviously, this can be very, very dangerous. Rumination disorder. So this is the constant regurgitation of food, re-chewing of food, re-swallowing of food, also very dangerous. And orthorexia. So orthorexia is not in the diagnostic manual, but a lot of clinicians and therapists are advocating for this to be properly treated. And what this is when an individual is obsessively consumed with eating only healthy and organic foods. So a lot of times I hear people say, that doesn't sound that bad. They're really careful about their health. It's a little different. It's more than just health because they become obsessed with it and they avoid things that maybe aren't organic or things that don't have a specific nutritional value. This can be very dangerous and also is a very restrictive disorder. So anytime someone is restricting certain things, it doesn't have to serve as like a medical purpose. It should be taken very seriously. I didn't put the next thing down on the slide, but I just briefly want to talk about body dysmorphia. And what that is just when someone is preoccupied with their size and weight, or maybe seeing something different than what others are perceiving them, and they become really preoccupied with trying to change or how others are perceiving their body. The reason I wanted to mention that is a lot of times someone who suffers with body dysmorphia, they also may experience an eating disorder. And I'll discuss a little bit more about that later. So next I'm going to talk about some of the warning signs. And I say some because these certainly are not all. If I had enough time, I would probably talk about each eating disorder diagnosis and talk about specific warning signs for each one. But since we don't have that time today, I'm just going to talk about some general emotional, behavioral, and physical signs that you might want to look out for. So preoccupation with diets and talks and body image. So if you start to notice your child or your teen be really focused on their body image and different kinds of bodies, that would definitely be considered a warning sign. Unfortunately, diet talk is everywhere. It's on the magazines, on social media. But if you really start to notice your child is really focused on that, I'd be really mindful and intentional to address that. If your teen or child is avoiding or eating around others. So if someone's avoiding to eat at family functions or go out with their friends and eat, that would definitely be a warning sign. Cutting out specific foods if it doesn't have like a medical purpose behind it. So if we're cutting out foods, so for example, I often hear people say, oh, I'm cutting out sugar this week, or I'm not going to have carbs this week, or I'm a vegan now. And if there's no moral or ethical meaning behind that, that would be a form of restriction and also a warning sign. If someone's skipping meals or eating small amounts of food, refusal to eat certain meals or anxious when eating. So if you start to notice that eating specific foods is causing a severe anxiety producing situation, that would be a warning sign. Extreme worry about their appearance, specifically regarding weight. Now, listen, I notice a lot of teens, and I think everyone in general at some point has some kind of focus on their appearance, unfortunately, because it's everywhere. But if you start to notice your child is really focused on that, then I would also be mindful to address that. Preoccupation with nutritional content. So I discuss orthorexia. So if you start to notice they're like, well, how many calories in this? Or what's the benefit of me eating this? If they're really focused on that. And the use of laxatives or diet pills. So some physical signs you could look out for would be extreme changes in weight. So that could be extreme weight loss or extreme weight gain in a short amount of time. Irregular menstrual cycles, difficulty sleeping. So maybe they're sleeping too much or they're struggling to fall asleep at night. It's a pretty big indication. Muscle weakness, dental concerns, dry skin, brittle nails, dizziness, feeling cold, and GI issues. And again, these are just some of the signs. And just because someone might have one of these does not necessarily mean there's an eating disorder, but it really focuses on like how much it's consuming your child and how often they're happening. Which brings me to this. So I wanted to talk about how to tell the difference between distorted eating and an eating disorder. I really wanted to talk about this because I'm sure a lot of people might watch this, be like, oh no, I see my kid do this one thing, or I do this. Does this mean I have an eating disorder? Well, not necessarily. What you want to do is explore the extent that the distorted eating is affecting one's daily functioning. So some questions you could ask is the preoccupation with food and size interfering with levels of concentration and focus? Is this all one can focus on? Are they only focusing on their body size or their food consumption or their lack of food? Is food or lack of food becoming a way of coping with stressors? While it's certainly okay to use food as a coping mechanism, food is comforting. If someone's using lack of food as a coping skill, that certainly can be really concerning and also is a form of restriction. So if that becomes someone's main focus, then you really want to explore with the therapist or your medical provider their form of treatment. Is social life becoming a stressor, or socializing with others being avoided? So if someone is constantly avoiding like going to school or going with friends or holidays or family parties because food, then that just shows how severe the disordered eating has become. And you also want to ask, how severe is the preoccupation with food and weight? How much anxiety is being experienced? Maybe there's a little bit of anxiety, or maybe it's a lot of anxiety. Either way, whether one is experiencing disordered eating or an eating disorder, both should be taken very seriously. That being said, because disordered eating can often cause an eating disorder too. So if someone might start with, oh, you know what, like I'm just not going to have sugar. And then it becomes, well, I'm not going to have these carbs. And then turns into, I'm only eating protein. So it's a really slippery slope. So if you even notice one of the symptoms I mentioned before, or the warning signs, it's important to be taken seriously. You can explore the extent of the eating disorder or disordered eating with a therapist or your primary care physician. But either way, I can't stress enough, they're just really important to be addressed.
So sometimes a person might have an eating disorder and they will also have another mental health disorder along with it, or they might not even have the eating disorder diagnosed. It might show up as something else. So what we have listed here are some of the things that maybe come along with having an eating disorder. First on the list is depression, which makes a lot of sense. If you have an eating disorder, you don't always feel really great about yourself. And also if you're restricting, you can have low energy, low motivation, stuff like that, that looks like depression. Depression also kind of like goes hand in hand with like the low self-esteem. So, you know, you're not feeling your best. You're not feeling very confident. You're feeling kind of blah. Anxiety also comes along with an eating disorder. Alex mentioned that a little bit. So people can get anxious around eating itself, or being in situations where there's going to be food involved. And then there's also guilt and shame, which is huge with eating disorders, especially with the binge eating disorder, I would say, because people will eat all that food and then they feel really guilty about it. And they feel bad about themselves, and then they're all anxious, and then they can be sad. And so it's like all just one big thing, right? Like it can all be intermingled. PTSD is another one. So if somebody is diagnosed with PTSD, post-traumatic stress disorder, it means that they have experienced a traumatic event in their life and then have, since the traumatic event, have developed PTSD. And a big part of that is control. And so when they feel this lack of control because of the trauma that they've experienced, like when you develop an eating disorder, it's a form of something that they can control. So it's almost like the eating disorder becomes a way of coping with the PTSD, which is interesting. And you can see this especially in people who have experienced sexual abuse, because they're focused on their body, and they are focused on not wanting to necessarily be attractive. If they're not attractive to others, then others won't touch them, which can lead to like the whole overeating, binge eating, and they kind of stay in this place where they again are kind of using the eating disorder as a way of coping with the trauma.
So I just wanted to review the 9 truths about eating disorder. I think there's a lot of stigma out there, and I really just thought this was important. And I gathered this information from the National Eating Disorder Association. So number 1, many people with eating disorders look healthy, yet may be extremely ill. So this is so important to address because so many people are not treated properly or not treated at all because they look healthy. Truth is, you cannot judge someone's health by their size. So this one is so important to know that an eating disorder can impact anybody. And just because someone looks healthy doesn't mean they are. So number 2, families are not to blame and can be the patient and provide as the best allies in treatment. So I also think this one's so important because, you know, when I work with someone with eating disorder and I work with their families, I've noticed a lot of people a lot of parents take responsibility. Oh, maybe I shouldn't have said this, or if I would have done this. It's so important to know that families are not to blame. Information about diet and body image, it's so ingrained in society and has such a negative impact on us, and it's certainly no one's fault. So I think it's very important for families to know that they are not to blame. 3, an eating disorder diagnosis is a health crisis that disrupts personal and family functioning. Eating disorders are so serious and they're so complex and they can be so dangerous, and it certainly is a crisis. It's not just eating food, it's so much deeper than that. And it's certainly important to get addressed. 4, eating disorders are not choices, but serious biological influence illness. This one is so important to tell people because I often hear people say, well, why don't they just eat, or why can't they stop eating? This is not a choice. Eating disorders are not that easy. As I mentioned, they're so complex and there's so much behind them to understand that it's important to know it is very serious and it is an illness. Eating disorders affect people of all genders, ages, races, ethnicities, body shapes, weights, sexual orientations, and socioeconomic statuses. Eating disorders can impact anybody. Eating disorders can carry an increased risk for both suicide and mental complications. Genes and environmental play a role in the development of an eating disorder. Genes alone do not predict who will develop an eating disorder. And lastly, full recovery from an eating disorder is possible. Early detection and intervention are important. So it's very important to know that recovery is very much so possible, but early detection is very important.
So I know we're like throwing a lot of information at you guys all at once. Does anyone have any questions so far?
So I'm going to talk a little bit about what causes an eating disorder. This is such a tough question to answer because there's just so many different things that could cause an eating disorder. And I recognize we don't have all the time in the world to talk about it, so I'm just going to talk about some things. So there is a biological component, genetics and neurotransmitter abnormalities. Dr. Nuthi, who will be speaking in a little while, will talk a little bit more about that. There's psychological, so obsessional perfectionism, personality traits, and anxiety can cause an eating disorder. And society, so diet culture, weight stigma, social media, and thin ideas. This is a huge trigger and cause for an eating disorder because it's everywhere. And of course, a history of trauma. Whether it's sexual abuse, physical abuse, or any kind of trauma, this certainly can cause an eating disorder. So I have this book here, it's called The 8 Keys to Recovery from an Eating Disorder. And in this book, in the chapter, they talk about how it's not about the food. And they give some really good examples of what else could cause an eating disorder. So I just wanted to share some examples with you. So one thing could be poor self-esteem, a need for distraction. So oftentimes individuals with an eating disorder often use their eating disorder as means of coping and means of distraction. So coping skills serve as a distraction, but there's a difference between unhealthy coping skills and healthy coping mechanisms. So symptoms of an eating disorder often serve as an unhealthy distraction. Fill up emptiness. So someone with binge eating disorder, for example, might be trying to fill up some kind of emptiness or loneliness. The belief in a myth. So if I'm thinner, I'll just be happier. A drive for perfection. High achievement oriented. A desire to be special or unique. So for example, maybe I get attention for my eating disorder, or maybe I get a lot of attention for my willpower and self-control. Unfortunately, in today's world, it is idolized to have self-control over food or to look a certain way. A need to be in control. That's a huge one, and one I see so common. A desire for power over self or others or family. A desire for respect and admiration. Again, so I idolize for my self-control over my eating or my lack of. Difficulty expressing feelings. You know, like I said, an eating disorder is not about the food. An individual has a difficult time expressing how they feel, and that's why they're using unhealthy coping mechanisms. So a lot of the work an individual with an eating disorder will do is learning how to identify and express their feelings. A lack in trust in their self or in others. An intense fear of not measuring up. So for example, I know I can't compete, so I let my eating disorder take me out of the running. So that's again from the 8 Keys to Recovery from an Eating Disorder, but I think they're just really good examples of some of the reasons that cause an eating disorder. But like I said, these are just some of the examples, but there's just so many reasons that can cause an eating disorder. And like I mentioned several times, it's just so complex and it really varies on the individual and their history and their family dynamic and their genetics. So next I'm going to talk about different treatment options. So recovery should include physical, psychological, and behavioral support. So recovery for an eating disorder is a team effort, including personal support, medical support, and therapeutic support. It's so important to have a team effort involved in this, not only is someone's mental health impacted, but so can their physical health. So there are certainly different levels of care, and there's inpatient, residential, partial programs, intensive outpatient, and outpatient. So this depends on the severity of one's symptoms. So for example, if one might go inpatient or residential if they need weight restoration or their vitals are down and they need help getting their health back to where it needs to be. Partial program, that's usually a group therapy program that's usually Monday through Fridays. And usually one goes there once they're discharged from inpatient or residential. Intensive outpatient is therapy 2 to 3 times a week usually, and outpatient is just usually therapeutic support. You can decide the level of care your child or whoever you're caring for might need through your medical provider and your therapist. This is a pretty critical part in treatment, so it's really important you find the right fit because, again, eating disorders are so dangerous. So I mentioned outpatient therapy, and so I'm going to just talk about some of the different types of therapy. There are so many different types of treatment modalities when it comes to treating an eating disorder. And because there are so many different types of eating disorders, the treatment modality might vary, but I'm just going to talk about some of the most common ones, and they're pretty broad. So one type of therapy is dialectical behavioral therapy. And this is an evidence-based practice that teaches skills. And someone with an eating disorder, it's really important that they learn healthy coping mechanisms. For example, if someone's restricted and they need to learn to eat again, that could be really uncomfortable and it can bring up a lot of emotions. So dialectical behavioral therapy will teach a lot of different skills like mindfulness, emotion regulation, distress tolerance, and crisis intervention skills that can be really helpful for symptom management. Another type of therapy that is important and I think pretty critical in treatment is family therapy. It's really important, as I mentioned, to have a team involved in this. So having a child or teen's parents or caregivers involved is super important. When I work with a teen or a child, I always tell them, you're just with me for an hour. You're with your family the rest of the time. So it's so important that they know the coping skills involved. Acceptance and commitment therapy, another treatment modality that teaches behavior modification. And cognitive behavioral therapy is also a pretty important treatment modality. This is a pretty structured treatment approach, and what it does is it helps an individual challenge negative thinking processes. So for example, if one would think, if I was just thinner, I would be happier. Cognitive behavioral therapy helps challenge that negative thoughts and looks at other perspectives. And group therapy. Group therapy is super important in treating eating disorders because having an eating disorder can feel so lonely and so isolating because it is so difficult. So being with others really helps normalize the experience and you can gain much more support. So I think that is such a critical part when getting treatment. And group therapy would be involved in inpatient, residential, and partial and intensive outpatient. So I wrote down body image. So earlier I talked about body dysmorphia, and body image work is pretty important when treating an eating disorder because a lot of times people with eating disorders often struggle with body image issues. So a big part of treatment will be learning to not only build self-love, but also look at your body in different ways. So maybe work on body tolerance or body neutrality or body gratitude. But body image work is really just learning to cope with the changing body. It's so important for individuals to know that their bodies are always changing and there's no good bodies or bad bodies, just bodies. They're all good bodies, but body image work will teach them how to cope with the changing body. And in eating disorder recovery, sometimes bodies do change, and that's okay. It's about learning skills to cope with them. So I also put down yoga embodiment. So a lot of eating disorder work that I would do is learning to help view your body and feel comfortable in your body. So learning to identify how you're feeling internally rather than focus on the external piece of your body. So I always tell my clients that I'm working with, it's not about your body, but it's how you view it and it's how you feel in it. So a lot of treatment is about focusing on how you're feeling inside and how to cope with the negative feelings rather than acting on behaviors that are causing you more harm. Also by building confidence. Another important treatment option is medication management. And lastly, seeking a dietitian or nutritionist. So it is so important for an individual with an eating disorder who is seeking a dietitian to be very mindful and intentional that they're finding someone who specializes in eating disorders, who is health at every size informed and is anti-diet. Diet talk or someone who focuses on weight loss can be very triggering and make symptoms worse. So it is very important that the dietitian is very well informed in eating disorders. So how can you help? First thing is understand your own weight bias. I think we all have them. How could we not? Everything we see talks about weight loss and You know, if you lose weight, you could feel better and you can look better. The truth is, it's really toxic. So first and foremost, it's important to understand your own weight bias. Second, no diet talk. This can be really hard. I don't think I go a day without hearing someone talk about diets. It's the truth. It is everywhere. It's like when I'm checking out the grocery line, or I'm at work, or I'm with a friend. Diet talk is everywhere. So this one can be really challenging. But it also can be really triggering for your teen or your child, especially if they're struggling with an eating disorder. And if they're not, it still can be really triggering. So I just encourage everyone to really, really be mindful of what they are discussing at home, and specifically work on not talking about diet or anything about someone's food choices. So next would be focus on traits that are more than just a body. So I often tell my clients that their body is the least exciting thing about them. You know, individuals have so much more about them externally and internally, and it's so important to focus on their strengths and their characteristics other than their body. You know, so really just being mindful, you're focusing on things they accomplished well that day, or other things you notice, or hey, I noticed you helped a friend today, that was really great, or you did really well on your math test, rather than focusing on the body. Normalize food. So there's no good food, there's no bad food, there's just food. I get this one argued with me a lot. I'm well aware that there are more nutritional benefits in some foods than others. But when working with eating disorders and people who have a ton of food rules, it's so important just to normalize food. So in some treatment options, a lot of therapists and nutritionists are going to work with the client or struggling with eating disorder on intuitive eating, learning to trust their bodies again, learning to just honor what they're craving, honor what their body needs, and learn to trust what their body needs again. One thing that will help with that is just normalizing food in the home and where they're at. So if an individual has an eating disorder, they often have food rules. What food rules mean is, oh, I'm not having sugar, or I'm not having meat, or I'm not having carbs, I'm not eating past a certain time. So a big part of treatment of eating disorders is working to eliminate those food rules. So one way that would really help with that is just normalizing food. Food is just food, and you will learn to trust what your body needs again. And lastly, another way you can help is educate and advocate. Educate yourself on some of the stuff, and that comes with understanding your own weight bias, and advocate. So that could be if you hear someone talking about diet in front of your child or your teen, maybe gently pulling them aside and being like, hey, I want to talk to you, how triggering that could be. Eating disorders can be, if you have an eating disorder, it can be really triggering to advocate for yourself, especially in the early recovery. So it's nice to have people advocate for you. So one way you could help is advocate for whoever you're supporting. So I mentioned health at every size. So I just briefly wanted to discuss with you guys the 5 principles of eating at health at every size. So first is weight inclusivity. Accept and respect the inherent diversity of body shapes and sizes, and reject the idolizing and pathologizing of specific weights. So it's just really understanding that there are so many different body shapes and sizes, and eliminating the thin ideals that are out there. And I'm going to show a video next that further explains that. So health enhancement, support health policies that improve and equalize access to information and services, and personal practices that improve human well-being, including attention to individual, physical, economic, social, spiritual, emotional, and other needs. Respectful care, acknowledge our biases, and work to end weight discrimination, weight stigma, and weight bias. Provide information and services from an understanding that socioeconomic status, race, gender, sexual orientation, age, and other identities impact weight stigma, and support environments that address these inequities. Eating for well. So promote flexible, individualized eating based on hunger, nutritional needs, and pleasure, rather than externally regulating eating plan focused on weight control. And lastly, life-enhancing movement. Support physical activities that allow people of all sizes, abilities, and interests to engage in enjoyable movement to the degree that they choose. So I like the last two, especially for eating eating for well because it's, not only eating for because you need to, but eating because you enjoy it. Food should be enjoyed. Food's everywhere. And it should be a thing that's celebrated and you really enjoy. And same with body movement. A lot of individuals with eating disorders, they exercise compulsively to lose weight and it become really unhealthy. So a big part of treatment will be just learning to do body movement that feels good and doing it for your mental health rather than just trying to lose weight. So we're going to show a quick video. It's called The Poodle Science, and it discusses health at every size a little bit more, and it's really interesting. So I just thought that was so helpful to share. And just, it really explains the health at every size concept and how weight stigma can be really damaging to individuals and even sometimes cause an eating disorder. So I just wanted to share that, and I hope you guys found it as helpful as I did. And does anyone have any questions on that so far? Like Alison said, we know I'm throwing a lot at everybody.
We also just saw in the chat that maybe you guys couldn't hear that.
Oh no, I didn't see that.
Which is terrible. But if you can look it up on YouTube on your own and you maybe want to take a look at it, it really is helpful.
I'm so sorry, I didn't even see that. It is so helpful, and I can't stress enough that you guys look it up. So it's just type in the poodle science or poodle theory on YouTube, and it's 2.5 minutes long. I'm so sorry about that.
It's really cute. The brief synopsis is that like the poodles are bossy and they think that all the dogs should be like the same weight as poodles, but every dog is different. Like there's labs and there's mastiffs and there's bulldogs and pit bulls and whatever. So like they have to be at their own healthy weight, and they, a starving mastiff is it's never going to be a poodle. So, which is trying to illustrate the health at every size. So it does, it's great. It was really cute. So sorry, guys.
And basically it summarizes, all bodies are just different. Each one of us are just so different. And it ties into eating disorders because I think a lot of mistreated because of maybe the number that's on the scale or the BMI. And honestly, that might not make all the difference because some bodies are just bigger and some bodies are just smaller. And just like the video showed, we're just also different, and our treatment should be tailored to who we are as an individual. And we shouldn't all just be told to be poodles, essentially what that video is saying, because we all are different and our body needs a lot of our bodies need more food and some of our bodies need less food. It all just depends. But weight certainly should not play a role into that at all. And I can't stress this enough because unfortunately I've known a lot of people that have not been treated properly because of the weight on the scale. So that's why it's so important to find a medical provider that focuses on health at every size. And I know Dr. Nuthi is speaking to us. We have a slide too, right?
Yes.
Okay.
And thank you, Jessica. She just posted the link for the video in the chat too. So if you guys would want to take a look at that at some point, please feel free to do so. As we have mentioned throughout this presentation so far, the family is really important in the treatment of the eating disorder. So this slide is illustrating a little bit more about how the eating disorder affects the family, and the family can also affect the eating disorder. So of course, there's going to be some conflict involved here, because here you are, you're the parent, you're the caregiver, and your child is really struggling, and you're watching perhaps their physical health decline, and it's scary, and all you want them to do is be healthy and be okay, and coming in and trying to force eating, or making rules about not going to the bathroom after eating, whatever it might be, it's just not gonna end well. It's going to be a fight. And so the conflict comes about, when the child, teen, whatever, is dealing with the eating disorder and the symptoms, and then the family is trying really hard to correct the symptoms. And what really needs to be starting to happen, and can happen with the help of family therapy, is for everyone to start sharing what's really going on. What's the underlying issue here? It's the anxiety and worry, it's the depression, it's the self-esteem, it's whatever else might be possibly going on. But of course, then within your family dynamic, there is going to be anxiety, there's going to be worry, you're going to be afraid for your child, and they're also dealing with their own stuff, their own anxiety about eating, or worries about being out in public, or being around friends, or having to go to that family picnic. Of course, there's going to be a certain amount of attention given to the eating disorder because it's a big deal, right? But we have to focus, kind of like what Alex was saying, like that food is food, and we have to watch what we're giving attention to when we're at home with our teen or our child that is struggling with something like this. Something else to keep in mind is if you have other children in the home. And so this can take up a lot of time and energy because there's a lot going on here. And you have to be careful about, still including everybody in the house in the family dynamic and giving attention to them and to their needs as well. Just one of the many things we do as parents, right? One of the juggling acts. Which leads to my next point, which is self-care. So this is something Alex and I talk about in every workshop because it's super important, and people don't do it because you don't have time, or you ran out of time, you were planning on doing it, but then you had to do this instead. And there's always a reason, right? That we're not taking care of ourselves. So what we like to tell people is to try to do at least one little thing for yourself every day, whether it's like having your coffee by yourself in the morning, having a piece of dark chocolate at night, taking like your 15-minute walk after dinner, or like walking the dog in the morning, whatever it might be, just making sure that you are making that time for yourself so that you can just be, and it doesn't have to be about whatever stressors are going on in your life or whatever the next thing needs to happen. And you can also do these things as a family. which can also help to kind of like distract from, okay, like, again, any issues or stressors that are going on in the household. Like, let's just all sit down and watch a movie. Like, let's just all tell some jokes or whatever it might be. Let's watch the rain, the thunderstorm. But trying to take better care of ourselves is really important, and trying to also then care for others. And a big thing with eating disorders is control, as we have mentioned throughout too. So the person with the eating disorder is often feeling out of control in other ways of their life. And so the control that they have over their eating provides some sort of compensation for that. And if you are trying to, as a parent or caregiver, control the situation, as we do, because we are trying to set up structure in the home, we're trying to have rules, we're trying to have limits, we're trying to like do all these things. And then your teen or your child who's really kind of struggling over here is having like their own sense of control issues, you're going to start butting heads, and then it turns into a power struggle. And then the next thing you know, there's a lot of frustration going on, and oh, they're not listening to me, but you're not listening to me, right? And so then this is all going on with this issue, that this kind of a battle for control. And so when you're really getting down to it in your treatment, in your family therapy, like trying to find out ways to get around the power struggle so that you're addressing the true issues and you're not just going to be butting heads and fighting. Did you want to share some statistics?
I would love to.
Okay.
So 81% of 10-year-old children are afraid of getting fat. Less than 6% of people with eating disorders are medically underweight. 28 to 74% of our risk for eating disorders are through genetics. 55 to 57% of adolescent girls engage in crash dieting, self-induced vomiting, diet pills, and laxatives. About 26% of people with eating disorders attempt suicide. Around 25% of male children or adolescents were concerned with masculinity. 42% of first to third grade girls want to be thinner. So I know some of these statistics are alarming. So I do want to say just recovery is very possible, and it's a lot of hard work, but I've seen it, it happens. And I know this is a lot of hard information, but just knowing that recovery is very much so possible. And I think we have time. Did you want to do the role play?
Yeah.
So Alice and I are going to role play. We do this each workshop just to kind of show some good examples and not so good examples on how to support someone who might be struggling. So in this scenario here, I'm going to be the parent and Allison is going to be my child. Let's just say she's my 13-year-old girl. We're about to have some dinner together. So just picture us at a dinner table, and I just placed our food down. And I noticed you're not eating.
Yeah, I'm not hungry.
You need to eat.
No, I'm really not hungry.
I made this meal for you and you need to eat.
It looks disgusting.
Well, you still need to eat it. Your skin and bones. You got to eat something.
Mom, I'm telling you, like, I can't do it. I just can't.
Well, it's not, watch me eat it. It's not that hard. You take the food and you put it in the mouth and you chew.
Yeah, okay, Mom, I get that. I'm not eating it.
All right, you know what? Then go to your room and you can just give me your phone for the night.
All right, good night.
Obviously not the best example. So in that, I was very dismissive, did not explore how she was feeling. I commented on her body, and I think it should be a rule of thumb that no one comments on anybody's body size. So right away, I commented on her weight, which would be super triggering. And I was pretty harsh in my tone. It was actually hard to role play that. I felt like I was being too harsh. So we're going to try that one again. And I'm going to try to be a little bit more gentler, a little bit more validating, a little bit more understanding, and trying to understand the root of the issue rather than trying to dismiss it and force my child here to eat, which can be hard, but we'll try now. I noticed you're not eating. Is something wrong with your food?
I don't know. I don't know if there's anything wrong with it. I'm not going to eat it. I'm not hungry.
I'm surprised you're not hungry because you haven't eaten since lunchtime today.
How do you know I haven't eaten since lunch?
Because I care about you. And we talked about in therapy how you would try to eat your meals throughout the day. You seem upset. Tell me what's going on.
I don't want to eat this, Mom.
I know you don't. But
You have no idea. Like, I'm just like, almost like literally physically like feel sick right now. Like, I'm so anxious. It makes me just like I can't.
You're right. I don't know. And I couldn't imagine to know what you're going through. I know this has been so difficult on you. But I also know that you're a human and your body needs food. But I know this is so hard on you.
Mom, you don't see it. Like, you don't look on social media and see these girls and what they post and what they look like.
Yeah.
Like, I don't look like them.
Well,
I can't go to the beach and look like that. There's no way. Like, Sophia wants me to go to the beach with her next week. I can't go. I can't do that. I can't eat this and then go to the beach with Sophia.
Because how's that making you feel? How do you feel? We know this is nothing about the food, not about your body. So tell me, how are you feeling when you see when you're seeing those things on the internet and social media and you're seeing your friends? What do you feel?
I feel sad.
Yeah, that's hard. I know it's hard to feel sad. I know it's hard to compare yourself to others. And I know, and I hope you know deep down, you are enough. But we both also know that you have to eat. So how can I support you through this? Because I want you to know we're going to do this together. And then the coping skills that you learned in therapy, why don't we practice them?
Okay.
So, and maybe if we were eating dinner together, we would both eat together and I would gently talk her through it. And maybe we would practice a form of distraction. If someone is being exposed to eating food again, or maybe even breaking one of their food rules, that could be really triggering for somebody. So maybe as a caregiver, I'm not going to be like, you need to eat, I did say our bodies need food because, the goal is to eat, right? In all diagnoses, actually, because in all the diagnoses, it's not about food. It's usually about the restriction that causes the side effect of symptoms. So in this case, I'm really trying to gently encourage Alison to eat while also trying to figure out what she's feeling and what triggered it. Because usually an eating disorder symptom, it's not about the food, it's rather about their way of coping with something. So instead of dismissing the food part, I'm really trying to explore, well, how are you feeling? What's going on? And then also trying to encourage, well, how can I support you while we eat? Because I know you're uncomfortable and I know you're so sad, but you still need to eat. So how can I support you through that? In this situation, obviously, I pretend like we're in therapy and using coping skills because you really want to encourage your child to use the healthy coping mechanism. This is a lot of hard work and this happens so organically, but I know this is not as easy as said. It's easier said than done at home. And I do want to recognize that, but it's going to take a lot of validation and understanding. And if you also notice, Alison talked a lot about comparing herself to others on social media and how she can't be in a bathing suit. It's so quick, I think, for a parent or a caregiver to want to jump in and be like, you look great, you're fine who you are. But I'm really trying to encourage parents to just not focus on the body type because all body types are just different, and of saying like, oh, you look fine kind of puts the emphasis on like, your values in your body. So I'm really trying to steer away from that in that conversation rather than validate, yeah, it's really tough being in this world where our bodies are constantly compared, and eventually work through that. Like your body is enough as it is. You are enough and, you're worth taking up space and, you still need to eat. So there's a lot of pieces to this. And I understand I'm throwing so much at you. And I guess it just shows how complex it can be. Anybody have any questions on that?
If there aren't any questions, then we are going to hand off the presentation to Dr. Nuthi. So if you want to go ahead and get started. Thank you.
Sure. Hello, everyone. Adding to Alison and Alex's presentation of this complex condition, but also acknowledging that there is a lot of hope. It's the treatment is hard, but it is definitely fruitful. Eating disorders are psychobiological disorders in the truest sense, because eating behavior satisfies a basic biological need and is intimately involved in personal relationships. The child's biological and emotional lives are closely intertwined in the eating process. Feeding and eating are central to the bonding between the infant and the mother. And of course, as Alison and Alex pointed out, eating has important social and cultural implications. Eating disorders are a group of psychiatric disorders with significant and potentially fatal medical complications requiring early detection and treatment for optimal outcome. Eating disorders are often underdiagnosed and undiagnosed. Adding a few more statistics to Alex's statistics, about 9% of the population worldwide actually struggle with eating disorders, which equals to about 20 million Americans. Eating disorders are definitely a lot more common than schizophrenia, and some other conditions. Less than 6% are actually medically diagnosed. About 1 to 2% of females and 0.1 to 0.3% of males develop anorexia, and the numbers for bulimia are about double of that. And binge eating disorder is about 3 times more common than anorexia and bulimia combined. Young people between 15 and 24 years of age with anorexia have 10 times more risk of dying compared to their same age peers. Males represent 25% of individuals with anorexia nervosa, and they are at a higher risk of dying, in part because they're often diagnosed later, because many people assume that males don't have eating disorders. Research and clinical reports show that the age of onset of eating disorders is getting earlier in both males and females. Oh, where's my cursor? The neurobiology of eating disorders. The exact cause remains unknown, and there are several factors, as Alison and Alex mentioned. About 50% of the risk for eating disorders is through genetic heritability. Since eating disorders reflect a discrepancy between the physiological need to eat and the drive to eat, it has been hypothesized that these individuals have a fundamental disturbance of appetite regulation. Brain imaging studies have the neural pathways that play a role in emotions, reward, salience, and inhibition of eating. Dysregulation in the systems that integrate behavior with eating can override the homeostatic or balancing signals. So this area, the limbic pathway, including the amygdala, controls the emotional part of eating. It informs us of the perceived importance of food and also processes the basic sensory information about food, like smell, taste, things like that. The cognitive part, the cognitive pathway, controls the planning and the judgment part of the eating process. The midbrain structures, like the nucleus accumbens, putamen, and caudate nucleus, they mediate between these two parts. And they mediate by coding for the rewarding and motivating value of eating and contribute to either approach or avoidance behaviors. These systems interactively weigh the reward value of food and the consequences of consuming it, and they integrate this information with the homeostatic and the motivational drives to guide eating behaviors. The faulty reward processing system involves the neurotransmitter dopamine. Interestingly, dopamine action is altered in both anorexia and bulimia, but in opposite ways. In anorexia, there is difficulty coding for the reward and an oversensitivity to punishment. In anorexia, the release of dopamine will trigger anxiety rather than pleasure. There are similarities and differences with substance abuse. Particularly, the similarities are with bulimia nervosa and binge eating disorder, including problems in the interconnected reward and inhibition circuits. Increased rates of drug and alcohol abuse are noted in people with binge eating disorder and bulimia. Patients with bulimia nervosa or binge eating disorder show deficient activation in the brain regions that are involved in inhibitory control. Also, they show increased activation in response to the food cues, just like the increase in activation in these regions seen in substance users exposed to drug-related cues. And these similarities in brain activation are likely related to the underlying similarities in the neurotransmitter activity, especially dopamine. In contrast, the rates of drug and alcohol abuse are decreased in patients with anorexia nervosa. Individuals with anorexia nervosa demonstrate opposite patterns of neural activation in response to reward compared with persons with bulimia nervosa or substance abuse. The over control of individuals with anorexia nervosa might actually be a protective factor, protecting them from developing dysregulated substance use. The differential diagnosis and comorbidities associated with eating disorders, psychiatric disorders like obsessive compulsive disorder, there is some overlap with obsessive compulsive disorder, anxiety, depression, and drug and alcohol use. Endocrine problems like thyroid, diabetes, hypopituitarism, and Addison's disease or adrenal insufficiency. Gastrointestinal disorders like irritable bowel syndrome or celiac disease may have symptoms that mimic eating disorder symptoms. Same with some chronic infections like HIV, TB, and parasitic infections like Giardia, tapeworm, pinworm. These are quite rare in the US, but they are there and may cause loss of appetite and unintended weight loss. And other conditions that may cause very low appetite and significant weight loss. Routine screening of all preteens and adolescents in their annual physical exams is the key. Not just when people present with symptoms, as I think Alex mentioned, many adolescents with eating disorders may be within the normal weight range. So it's important to screen for all the other aspects of eating disorder. I will not go over some of the symptoms. I'm assuming I joined a little late, but I think Alison and Alex covered these. So some of the physical signs, even if kids don't admit that they have unhealthy or they're struggling with body image issues or eating issues. These are physical signs that can be seen, like low body temperature, low heart rate, low blood pressure, hypoactive, underactive bowel sounds, brittle hair and nails, hair loss, lanugo hair, which is kind of the very fine baby hair, cold hands and feet, and heart murmur. For bulimia nervosa, it's often kids or teenagers have scars or sores or calluses on the knuckles of their hands from repeatedly trying to induce vomiting, damaged teeth and gums, erosion of dental enamel, swollen cheeks from enlarged salivary glands due to repeated stimulation by them inducing the vomiting. Petechiae or like dot, like red spots, which are broken blood vessels in the eyes or face from repeated purging and changing weight, going back and forth. The workup starts with a thorough physical exam, of course, monitoring the body mass index, labs, including complete blood cell count and metabolic panel, liver function test, thyroid, sedimentation rate, etc. EKG to make sure there are no cardiac arrhythmias. In girls or women who have amenorrhea or who have missed their periods for about 3 months or so. It's important to do a pregnancy test, of course, and check for luteinizing hormone and follicle stimulating hormone, prolactin levels. In boys, it's important to test testosterone levels. Of course, this is not routine. It's the workup. You progress through the workup depending on some confirmation that there may be concern about an eating disorder. And CAT scan, MRI, mostly really to rule out other conditions like pituitary issues, things like that. And upper and lower GI gastrointestinal studies. And bone density studies in girls who missed their menstrual periods for more than 6 months, and in boys with low testosterone levels and severe malnutrition and very sudden severe weight loss. Eating disorder can affect every organ system. Children and adolescents are particularly more at risk due to their phase of active growth and development. Medical complications need to be addressed immediately. Majority of the medical complications resolve after judicious nutritional restoration and resolution of unhealthy eating behaviors. Some potentially irreversible medical effects include growth retardation, loss of dental enamel, pubertal delay or arrest, infertility, not reaching the peak bone mass, causing people to be at a higher risk of fractures. Treatment implications. It is extremely important for us to keep emphasizing that it is not anyone's fault. Helping a patient and family understand that eating disorder is not just behavioral, that there are brain circuits that are not functioning properly, that can help them engage in and adhere to treatment. Early, intensive, integrated, multidisciplinary treatment is critical and leads to better prognosis and outcomes. Weight restoration is an essential prerequisite to full recovery in anorexia nervosa. So some of this might sound a little contrary or confusing in terms of the softer approach that Alison and Alex had talked about. And I would say it's important for families to take the soft approach. But there are also in severe situations, it's important to take the hard approach. And I would say the professionals are very happy to support you with that, and even blame us for that. So weight restoration is an essential prerequisite. Waiting for patients to feel comfortable eating and start doing so on their own is often not an effective approach. Families need to be supported to feed their children despite resistance. Of course, the younger the child, the easier it is a little bit. But if the resistance is severe, hospitalization may be needed. The Society for Adolescent Medicine recommends inpatient admission for one of these criteria: weight less than 75% of the ideal body weight, dehydration, electrolyte disturbances, cardiac arrhythmia, heart rate less than 50 beats per minute, failure of outpatient treatment, uncontrollable restricting, binging, and purging, and of course, acute psychiatric emergencies like suicide attempts. If inpatient medical admission is needed for stabilization, judicious refeeding is essential. Slow, progressive advancement of balanced nutrition with the appropriate percentages of carbohydrates, proteins, and fat. Patients require close monitoring to watch for refeeding syndrome, which is defined as severe electrolyte and fluid shifts that occur in the early stages of rapid and injudicious nutritional replenishment. In a starved state, metabolism shifts to catabolism, which means breaking up of the fat and muscle tissue to get the energy needed to maintain essential basic bodily functions. With refeeding, the metabolism returns to anabolism, which is a state of body building and repair. And this requires increased uptake of electrolytes like potassium, phosphate, magnesium, and others. A sudden change in the concentrations of these electrolytes can stress the heart, potentially causing arrhythmias. Refeeding syndrome can affect almost every organ system, causing respiratory, cardiac, gastrointestinal, neurological, and skeletal problems. In very severe cases, if it's not recognized and treated properly, it can cause cardiovascular collapse and potentially death. But these are, once a child meets criteria for inpatient admission, especially on a medical unit, then obviously all these things will be addressed. In weight gain after semi-starvation or starvation, the fat deposition begins usually around the face and the abdomen. The mechanism for this is not very well understood, but it does redistribute over time. Understanding this pattern is vital for adherence to treatment. Otherwise, families may succumb to their fear of making their child fat and become non-adherent to treatment. For psychological interventions to be effective, medical stabilization and nutritional rehabilitation are imperative. Actually, research shows that weight restoration in itself improves the obsessive thought processes, compulsive behaviors, and mood lability. Medications. There is no FDA-approved medication for eating disorders in children and adolescents. Any medication trials in children and adolescents would be considered off-label, but potentially valuable. Fluoxetine or Prozac is currently the only FDA-approved medication for treatment of bulimia nervosa in adults. Vyvanse is an ADHD medication and an appetite-suppressing amphetamine, which is the only FDA-approved medication for treatment of binge eating disorder, again, in adults. The results of pharmacological studies for anorexia nervosa have mixed results despite frequent off-label use of medications. Prozac, Zoloft, and Lexapro are often used to address the underlying anxiety and depression. Benzodiazepines may be considered to address pre-meal and post-meal anxiety to help with the adherence to the plan. And atypical antipsychotics like Risperdal or Zyprexa may help when the distorted and ruminative cognitions around body image border on being delusional in quality or severity. The outcomes are definitely better for children and adolescents than for adults with early intervention. Majority of patients ultimately recover medically, behaviorally, and psychologically. On that positive note, here it is. Please feel free to type your questions. Thank you for attending, and I will turn this back to Alison and Alex.
Thank you so much for coming today. Again, if there's anything that you missed or anything like that, you're welcome to view this on our website at Lenape. At this time, are there any questions? All right. Thank you again.
Yes,
Thank you, guys.